Okay, today we're going to be looking at the how to use the Vivosonic signal averager for testing or using auditory brainstem response to evaluate and to estimate hearing thresholds in a baby, or to use it for retrocochlear dysfunction, typically in an adult or an older patient. Um, so there are a few things that I want to go over with you. In a previous video, I went over how to apply the electrodes, and in this case, we're using disposable electrodes. For the Vivosonic, the recommendation from the manufacturer is that you use disposable electrodes. So I won't be using silver chloride electrodes at all. And you'll notice that this is my daughter Maya. You'll notice that I have disposable electrodes on her ears, which I don't prefer. I prefer silver chloride clip electrodes, but people use this and it works. On a very small baby, which you probably would be using the Vivosonic, for which you would be using the Vivosonic, you might want to put the electrode pad right here on the mastoid. But the problem with putting it on the mastoid, that's kind of an unavoidable problem, is that if you have to use a bone conduction oscillator to rule out conductive hearing loss, you have to put this on the mastoid. So what you're going to have is an electrode on the mastoid, as well as needing to put a bone conduction oscillator on the mastoid. So what I say is to choose your best place for the bone conduction oscillator and don't put your electrode right there. Save that for the bone conduction oscillator. Right now I'm touching bone, and then I would put my electrode further down. So that's the only downside that I see to using the mastoid. A newborn's ears are so tiny that it would not sit as well as it's doing on Maya's earlobes here. So you probably would have to put it on the mastoid. But remember that you have to rule out conductive hearing loss in many cases, and you'll have to share that space with the bone conduction oscillator. You can turn your head back around. So now I want to show you the preamp for the Vivosonic. And this is the 2-channeled Vivosonic that I'm going to be demonstrating to you. And I like this piece of equipment. Here at Central Michigan University, we use this a lot because we test a lot of babies. And the Vivosonic is equipped with Kelman filtering, which actually works in a way to not give you as much artifact. And it's able to continue to average the responses in light of the fact that the patient may be moving. So if you were to watch any of their videos, they'll show you babies walking around, parents walking around holding the babies. We don't do that. I still think that it's a better test when the baby is quiet as can be, preferably sleeping. So while it will still continue to work, it just takes a longer time. So we like it and we use it a lot. I want to show you that the Vivosonic also follows the Jasper 1958 1020 system, in that the left ear is going to be channel 1 and the right ear is going to be channel 2. There's a little trick in it though, because on the screen that I'm going to show you when we begin the test, channel 2 is going to be on the left and then channel 1 is going to be on the right, sort of like it is here, 2 then 1. So don't get this twisted. Channel 1 is over here, which is the left side, and channel 2 is over here. And if you don't really know the 1020 system, and if you don't follow the rule that the left ear goes first when you're doing electrophysiological techniques, you'll get kind of messed up. So what we have here is the black, and you have to follow colors with the Vivosonic because they have it tied into their preamp, which is down here. Oops, let's fix this again. This came out the ground, so I guess you got to make sure those are in tight. You have the ground, which is black. You have channel 1, which is left, which is blue. We have channel 2, which is red, which is right. And then the green here is the ground. I'm sorry, yes, the green is the ground. And you can see that it's color coded here. So if you were to change these, you'd have to change them in this box, but that just makes things complicated. I think that you should keep the color system that Vivosonic, that the manufacturer has indicated, and go accordingly. So what you'll see is I'm going to do a 2-channeled, and I'm going to put this blue electrode on her left ear, on her right ear at FZ, and this at nason. Typically, I would put the electrode on the disposable pad on the electrode, then place it on the patient. But because Maya's an adult, I'm just going to snap it onto her. What I'm not going to do is put it on her head and push it down into her head. That's not comfortable for a patient. Hold that for me for a second. What I'm going to do is pick up the end here. Sorry. I'm going to pick up the end here, hold it, and just snap that. So I'm not going to press into her head. That's just for patient comfort. Then I'm going to take the blue electrode, which is channel 1 for her left ear, hold the bottom and just put a finger underneath it and press it instead of pressing her whole head. And then I'm going to take 2, which is the right ear, put it on the right side, and I'm going to take the green, which is the ground, and put it there. Now this could be in a baby, which I'm not going to demonstrate today. But for Maya, I'm going to put them all behind her ear, and I'm going to ask her if I can just leave it there, leave it on one side. But I'm just going to hold this for right now. So this is how it will look during testing. And I have each of them on. This is the on button for this box. This box works by Bluetooth, which is another reason that we like the Vivosonic, because the mother or the baby or the father is able to be with the baby at a remote location, whether they're inside the booth or you're outside the booth or walking around, and they're not attached to the signal aperture with wires. So that's a really good thing about it. The bad thing about it might be, if you call it a bad thing, the disadvantage, I would say, is that the batteries can run out on you if you're doing, for example, a really long ABR threshold test. And so you have to keep an eye on how much battery charge you have. We have 2 battery chargers. We keep 2 to 3 of them. They look like this, and there's a battery pack that comes with them. These are rechargeable batteries that you can get from Vivosonic, and you place them right into the battery recharger just like this. We have been told that you have to, once you put them in, you have to disconnect them from the power and reconnect them to the power in order for them to be activated. There's a power indicator on the floor that has like a little green light that goes from green to yellow to red, and when it's on green, you know that the batteries are charged. So keeping the batteries charged is a really important thing, and for your labs, make sure that you always leave them on the charger. And so that's how we do that. So we have the battery chargers with the batteries. We've got the Vivolink, and I want to show you that on the back of the Vivolink is where we put the batteries, and be very careful because this compartment can break very easily. So when you put the batteries in, slide this in very gently and snap it, and then you turn it on and it'll work. The other nice thing about the Vivosonic is if you don't have rechargeable batteries, or you've seen a lot of patients and you've used up the battery life, you can use alkaline batteries for the Vivosonic. However, you'd have to go into the settings within the signal averager and change the type of battery that you're using to alkaline so it knows how to create the power for the system. Attached to the Vivolink, we also have our transducers, and you will remember me telling you in our previous video that when you separate the transducers from the electrodes, you get less artifact. And so what I'm going to do is have her, if this was a patient, I would actually run this around the back of her head, but I'm not going to do that right now, just for time's sake. But I'm going to run these from the front, and I'm going to have her and have the electrodes go from the back. So I'm just going to put these, clip these to her shirt, squish this. In a baby, you're going to use, of course, a very small insert. Sometimes we have to cut them in order to get them to fit. Can't understand why they don't make one really small enough for infants, but when I begin the manufacturing baby business, that's what I'm going to do. I'm going to make two things. I'm going to make a bone conduction oscillator that can fit a newborn's head properly and tightly, and I'm going to make some inserts that fit a newborn's head. I think whoever does that is going to be really in big business. Whoops, that's not good because that's leaning all on top of the electrodes. Let's see. All right, so I'm going to separate the electrodes as best I can from the inserts. Okay, so that is the setup of how a patient would look, an adult patient would look, if you were using the Vivosonic, and this would be for retrocochlear, or you could use it for a baby. If you didn't want to use two channels, or right and the left, and you wanted to use a non-cephalic channel along with an IPSI, you could have FZ to A1 for an IPSI, and you could do FZ to non-cephalic. I'm not sure too many people do that anymore, but it does give you a really nice wave 5 if you're looking for a wave 5. And now I'm going to show you the signal averager. And you're just going to have to remember what Maya looks like hooked up, because I'm not sure we're going to come back to her, but she's going to be the patient that we're going to use during our evaluation. And I can put the batteries back here. And what I did was turn on the computer. There's a turn on button here. So the Vivosonic comes with this notepad, this ThinkPad, and what I did was click on the icon that says integrity, and that will bring up the software. And once that software comes up, I hit diagnostic, because you can get different modules to go with this. So you can get OAEs, DPOAEs, or TEOAEs, I believe, and I think you can get ASSR. I'd have to go back and double check, but there are lots of different things that you can do to use it. Then when you hit diagnostics, you're going to get to this screen. This screen is going to show you there's patient name, the hospital, the general demographics of the patient, and there are various things that you can do right there. You can see, I want to point you to the battery. You can see that the battery is all green, and there's a blue light there saying that the Bluetooth is working. The VivoLink has a blue light here. It's on, so I know that the VivoLink is attached to the signal averager. And so you're going to keep your eye on the battery the whole time to make sure that you have enough battery life. Now, in order to enter the patient data, once you get to this page, you're going to have to scroll all the way down to the bottom. And there's some little directions at the bottom here that you can follow. So I'm going to scroll all the way to the bottom. And when you get to the bottom, you'll see that there is a blank space there. What you're going to do is click on the blank space there and you can start to type that you can see there. Or since I've already entered Maya, so I'm going to type, you can see that I can type it right in there, but I'm going to actually erase that. I've already entered all of her data. It's going to ask you for her birthday, those kinds of things, which doctor referred her. And I'm going to go down here and find her.
Can I come in now?
Yeah.
Okay.
Let's stop for a second. You know what I'm not getting? The questions in between.
Yeah.
Because I know there are 1,000. They're like, okay, could you show me that again? And how do you do that? And that entering of the patient, like when I do a practicum exam, do you know how many students can't enter the patient? And I sit here for like 10 minutes and they start to cry because they can't enter the patient in. And I just go, let me know, because I take off points if you need help. You need help? They'll go, no. So okay. I'm not able to really emphasize some things, which is, we'll just see how it works.
Can we go back? Because like when you were clicking on the empty field to enter her name, your arm was blocking that.
Oh, okay. So you want me to go up here and show how you have to go all the way to the bottom?
Yeah, yeah. So if we could start over.
Let me just.
Take her out again.
Okay.
And let me just.
So you mean where I was talking about the fact that when you come to this screen, you have to scroll all the way to the bottom.
Yeah.
Okay.
Yeah, and if you could just keep your body position right where you are right now, you're not blocking the screen at all.
Okay,
so.
Stay over here, kind of. Okay.
Yeah.
All right, let me. Okay.
I'm rolling, so whenever you're ready.
Okay, so now that we have hit the integrity button and the diagnostic button, you'll get to this page. Okay, do you want me to go over all the battery stuff again?
Yeah, why don't you?
Okay. Okay. So that means I need to show, well.
Or don't worry about it. I got it in the last one.
Okay, because I need to show them how to make sure that they look at this and that the battery.
Well, then why don't you do that? Just hold the, I'll just zoom back out. You just hold that up right in front of the screen.
Okay, there we go.
Yeah, if you hold it right there, I'll be able to see it.
Okay. Can you still see what's going on here?
Yeah.
Okay. Tell me when you want me to.
Go ahead.
Okay, now that we've hit diagnostic, when you first turn the system on. Okay, I gotta start again.
Whenever.
Okay. Now that we've turned on the machine and we hit integrity to open up the software, then we hit diagnostic, we get to this screen. And there's several things I want you to see about this screen. For example, there are patients, database, protocol, all, different things that help the software work. But I also want you to see this battery here and that blue light. That indicates what's going on with this Vivosonic. As long as that's green, that means that you're connected and the battery is full. As time goes on, that green will diminish, and you have to keep your eye on that to make sure that you have enough battery life to get through the frequency that you're using if you're doing a threshold ABR on a baby. That blue light tells you that you're connected via Bluetooth to the Vivosonic and everything is fine. So the battery is in, you've turned on the Vivosonic, you've booted up the system, and you have to boot up the system with the battery in and the Vivosonic on so that they can become, because they're in sync, and then you know you're ready to go. I'm going to put this back over here, and let's show you what's going on in this initial screen. When this comes up, these are all of the patient demographics that you can fill in. You don't have to fill in them all. We put in the patient's name, their hospital ID number, their gender. We have their address and things like that in their Epic chart, their date of birth. And for comments, you can put in that you're doing a threshold ABR, but we use comments actually to name the frequency of the threshold that we're collecting for that particular tracing. So what you're going to do when you first come in is scroll all the way to the bottom. And when you scroll all the way to the bottom, there's going to be a line at the bottom where you're going to enter in the patient's name. You're going to put in the patient's name and all of their information right there. And I've already entered in information for Maya, so I'm going to do the testing with her, which is right here. I'm going to check that, and then I'm going to hit enter. And you see up here, there's test. Now that I've highlighted her name, I can hit test. And now we're going to get to the Vivosonic screen. So this is the primary Vivosonic screen that you're going to use. This is something that I definitely have to show you. Remember, we've talked about the 1020 system and the left ear being channel 1 and the right ear being channel 2. And because all of our systems are set up like that, and I would say that most systems are set up like that in electrophys, I want you to see that on this piece of equipment, they have the left channel, which is the first channel over here in the right panel. You have to know that. So the left ear is in the right panel, but it is channel 1. The right ear is the first channel that you come to, but it is actually channel 2. And so if you don't get that straight, and you have a hearing loss, you're going to say the hearing loss is in the wrong ear. So this is left, channel 1. This is right, channel 2. Now over here, you can see the Kelman weighting. That's the kind of weighting that you're going to be using. That's going to be the system that gets rid of or takes into account the amount of activity or artifact in the signal. And you can read papers from Vivosonic about that. And we talk about that in class, whether or not you need filtering, masking. You can choose the polarity that you want. Here's where you can You can choose what level, at which level you'd like to begin. We start at 0, but here's a slide here for the intensity, or you can just type it in. I typically type it in. I want you to see here that as you're looking at the number of sweeps, again, for me, it's a little backwards. Channel 1 is over here, which is left, and channel 2 is over here. So when you're testing the left ear, this is going to be your ipsilateral channel, and this is going to be your contralateral channel. And you have to remember that, or you're going to interpret the data incorrectly. And the same goes down here when you're looking at raw EEG. You've got channel 1 over here, channel 2. These are your electrodes, the impedance for your electrodes. So when you check your impedance, they should be green and not yellow or black. Over here, you can see the patient's name. We just have a test Maya in there. And for protocol, if I open this up, you can see these are the different modules that you can have. ABR ECOG, ASSR, DP, OAEs, and TEOAEs. We're going to make sure that you have selected ABR ECOG. And then you can select a particular protocol for that particular run. Right now it says ABR air conduction 500 hertz with an alternating polarity. That's not what we're going to be doing. We're going to be doing air conduction click, and I'm going to use 37.7 clicks per second. And I'm going to choose that and see how that changes there. But I also want to show you here, you can do that. You can do bone conduction. We have it set up for 27.7 and 37.7. You can put in different frequencies that you'd like, whatever you desire. So you have those kinds of options. I hope you can see my cursor. The start button will toggle between start and pause, start and stop, and you have a pause button. These will all become highlighted once I start testing. I can check the impedance, and I can toggle between left and right ear here. Also, I want to show you, and I'm not going to go through this a lot, but you can look at the system, and when you're doing your lab, click into system. That's where you can change your parameters. However, what I suggest, and that because we have so many people using our system, is that if you change the parameters to ones that you prefer, that you give it a name that you can call up in the protocol, as opposed to going in and changing it every time. So it's not as readily changeable as some other systems are, but you can name your protocol with your selected parameters. And so you would have to go into system, and you can look through the different protocols. So take your time while you're going through your lab to look at what the capabilities are. I encourage you to read the manual, see what your capabilities are. I also want to show you down here at the bottom that you can look at, once you mark your waves, you can look at the milliseconds, the latency of the wave, as well as the amplitude and interwave latencies, etc. So we love the Vivosonic, and it's great for testing children and for testing babies. We often cheat and use it for retrocochlear pathology also. I don't really have anything bad to say about this system. We like it. All right, so we're going to check the impedance. Maya's all hooked up with her electrodes, and let's check. I rarely use it on an adult. So this is what you're going to get, and it's telling us to wait, and you can see that we're looking for, the impedance should be under 5,000 ohms. You can see that the ground is at 2,000 and everything else is within, or 1.5, and everything else is great. So we scrubbed her well. By the way, I used a dirty scrub on Maya, which is, I put the new prep on the alcohol, and it was not preferable to her as using the alcohol first and then the new prep. Patients seem to like when you do them separately, but for clinical efficiency, it is faster, but it's not more pleasant. All right, we're going to close that out. It's a little waiting time. So everything is really ready to go. I'm in my protocol. What I'm going to do is select my intensity. So I'm going to go to 90 dB, and I would recline the chair, make sure the patient is comfortable, instruct the patient that you're going to, you're going to, of course, you will have told them about the test, but you want them to relax with their eyes closed. They can fall asleep. They can put on a blanket. You can give them a blanket if they're cold. If there's a mother with a baby, she may need a pillow underneath her arm. You just want to make sure everybody is comfortable. The other thing is, if you're testing babies, often babies and children come with parents and grandparents and guardians and foster parents and all kinds of things. So you have to have your room arranged in such a way that everybody can fit. We've actually rearranged the room a little bit just because we're making a video, but we typically have the system against the wall with the patient here, and depending on how many family members come, I love to instruct them to wait in the waiting room, but you know, sometimes both parents would like to come in, and so we have availability for them. All right, so Maya, close your eyes, relax. And so what I'm going to do, I'm going to test the left ear first because I want to do channel 1 first. And as I always say, when you're doing electrophysiology, do it the same way all the time. Don't change what you do with every patient so that when something goes bonkers or they have a disorder or they have hearing loss, you're not questioning your technique. You know what you've done and you know the order in which you've done it. And if you practice that, I think you'll be in good standing. So we're in the left ear, 37.7 clicks per second. We typically do 27.7, but it kind of doesn't matter at this point. And I'm going to click start, and then I want you to watch the waveform grow. I'm going to go all the way to 2,000 clicks. We don't always go to 2,000 clicks in a real life situation, but I just want to make sure that we have signal averaged out most of the noise. So here we go, and I'm going to watch it grow. There's a little bit of a delay. You can see the EEG there. Now I want to show you something. I'm doing a retrocochlear ABR, but this is 25 milliseconds. I can put my cursor here, not quite on the black line, and I'm going to bring it over to 15 seconds because I want a shorter epoch for retrocochlear pathology. And I can better see that at 5.5 milliseconds where I need wave 5 to occur, I can see my wave 5 there. I can see my wave 1, 2, 3. I see a 4-5 complex there, and there you have it. Now up here, I'm looking at channel 1. If I wanted to see channel 2, I could click on this, on 2, so this would be my contralateral channel. My contralateral channel is going to give me my 4-5 complex, so I can see wave 5 here. So I'm actually going to choose my wave 5 as the shoulder based on the 4-5 complex that I get in my channel here. Now you can see over here that I have more than 2,000 sweeps. That's because I was talking, and we're going to rest it just like that, okay? And I'm just going to get rid of my channel 2 so you can see wave 1, wave 2, wave 3, and then we're going to do a replication. Remember, in electrophysiology, you always replicate. It doesn't exist if you don't replicate because you're trying to prove and document that it's not noise and that it's not random and that it's repeatable. So we're going to test again. I'm going to press start, and because I just have my first channel highlighted, and you see it's 15 milliseconds there. I've shortened my epoch. I'm looking for repeatability. Yellow shows that this is the waveform that I'm dealing with, and I can move that up and move it down. Let's see if it'll allow me to label it. See, it's not allowing me to label while I'm testing. Oh, yes, it is. So what I'm going to do is use where wave 5 is in my contralateral channel to mark the wave 5 there. I'm going to mark wave 4 where wave 4 is here. So I can come up, I'm going to be on this. Only mark one of your waves, not both of them. I'll mark that there. This is wave 1. I say mark while you're working, mark while you're averaging. We're going to stop that. So let's go to wave 2. I'm going to mark wave 2, and wave 3. I'm going to mark wave 3. So here we have it. So I've got 2 ipsies, 2 ipsies. That's the left ear. I could display my contralateral channels if I hit 2, but I'm just going to display my ipsilateral channels. I chose the, let me show you why I chose the wave 5 to be the shoulder, because look at this contralateral channel and look at wave 5 here and wave 4 there. If I were to bring them up, wave 5 corresponds to where I have marked wave 5 in my ipsilateral channel. Wave 4 corresponds to where I have marked wave 4 in my ipsilateral channel. So that's my rationale for choosing 4 or 5. People, everyone doesn't do it like that. Some people are just peak pickers, and I base it on the 4-5 separation of the contralateral channel. So that's the evaluation of the left ear at a high intensity sound, which gives you maximum synchrony to evaluate for retrocochlear dysfunction. So this is a neurodiagnostic auditory brainstem response test. Now we're going to do the right ear. I'm going to leave it at 90 dB. I'm going to toggle over here to the right ear, and Maya has has the right earphone in. My impedance is still good, and always check your impedance in between. My EEG is not going crazy. Everything else seems to be fine, so I'm going to press start, and this time you're going to watch this panel, and you're going to see that the ipsilateral channel will come up over here. So hit press start. Little time lag. Now notice that it looks a little bit different than this wave. That's because this has an epoch of 15 milliseconds, and this one still has an epoch of 25 milliseconds, so I need to change that. Remember, I'm going to take my cursor, I'm going to go way over to the left margin, but don't touch that black line. If you touch the black line, this won't work. So you're going to go over in that little space, and you're going to bring this over to 15, and then there you have equal epochs. So when you're doing this test, you want to make sure that you have equal epochs in both, for both ears. On this machine, you have to make sure that happens. If you do it on other machines, you set it in the protocol, it always comes up with the same epoch. So you could also, in settings, set this epoch to 15 milliseconds, so it would come up with that. But we use it for thresholds so much that we leave it at 22. All right, so here I can immediately look at my wave 1, my wave 5, but I can do that and see, whoops, I put a 1 there instead of a 5. Let's put the 1 over here. There we go. And before I do the wave 5, let me bring up my contralateral channel, which in this case would be my left channel. And I'm going to use this to help me choose where wave 5 is. And again, make sure you're on the correct. It even gives you a little handy dandy pointer there to tell you where wave 5 is. Isn't that fun? And then here's wave 4 over here. So I'm going to use my contralateral channel to also help me find where wave 4 is, just like that. I love that. And then, whoops, wrong one. You have to make sure the yellow is highlighted. That is the waveform on which you're going to be measuring, but it gives you a nice little cursor for the one below to help you measure things. Did I say I love this machine? I do. I'm not selling it. I'm not getting any money from Vivosonic. I'm just telling you what I know. All right, there you go. And we're at 4,000 because I'm talking too much. So you really need to do 2,000 or less. But what we know is that we really do have a response from the brainstem, and that there's very little noise in there. So we're going to do a replication. Some people wouldn't do a replication because I've done so many stimuli, but we practice replication, so that's what I'm going to do. Just the IPSI came up. I'm convinced that that replicates. I'll bring it down a little bit so you can see that. And there you go. And in real life, I probably run over 1,200 for the replication. I tend not to do less than 1,200. If I'm in a rush, I would do less if I know that it's definitely repeating. And as you go to your externships and practice, you'll get a gut feeling for what looks right. But you want to make sure that you can defend your response, especially when you start dealing with hearing loss and you're going to say to a parent that the child has hearing loss or the child has normal hearing when there's a question. You don't want to be guessing, you want to be sure. And there are other ways that we can be sure also. So you can also see how these are labeled. This is my fourth run. So if you start in the left ear, that was my first run. Then my second run was the replication. My third run was the first one in the right ear. My fourth run was the fourth run in the right ear. So they're numbered like that. So if you were to go to a screen or you're reading down here, you can see where you are. You can see 3R, that's my right ear. That way I can look down here and see what my latencies are. I can see the latency of wave 5 there. If I click on this, I can look at 1L and see my latency of wave 5 is 3.63. If I look over here, the latency of wave 5 is 3.53, 3.58. So what I know, and there's a little slider here that I can go back and forth. The criteria for intraoral latency difference between wave 5 between ears is 0.2 milliseconds. And there's literature to show that you can go up to 0.4 milliseconds. We don't go past 0.3, or I definitely don't go past 0.3. I start looking at the case history and other factors if I'm going to go past 0.3 to call it within normal limits, but this is definitely within normal limits. And again, here I'm talking too much and I've gone through too many stimuli. Remember, you do 2,000 or a little less. And here is your retrocochlear ABR. I leave my contralateral waves there in order to demonstrate my rationale for choosing wave 4 and 5 so that it's documented. And that's the end of that. But let me go on and show you how I would do a threshold. This is retrocochlea. So I did it at a high intensity at 90 dB NHL at a reasonably fast or typical rate of 37.7, and to get maximum synchrony along the basilar membrane. But if I were to try to determine threshold, I would have to lower the intensity to get what we call latency intensity function. And you can do this with clicks, or you can do this with tone bursts, or you can do this with chirps. So chirps don't have the typical latency intensity function that that I'm describing here, but that's a topic for a different video. So what I'm going to do is just show you right now. This is using clicks, and I almost never use clicks to do a threshold. I use the frequencies: 500 hertz tone burst, 2,000, 500, 1,000, 2,000, and 4,000, and 8,000 sometimes tone bursts with a cycle pattern of 202. And some of our clinicians use 212. But I'm just going to show you the latency intensity function. I'm going to come back to the left side, testing the left ear. I'm going to get rid of these two. And so what you're looking at on this left side is an ABR in her left ear at 90 dB. So just for the sake of showing you the latency intensity function, I'm going to show it to you at 60 dB, and then I'm going to show it to you at 40 dB, and I'm going to show it to you at 20 dB, and I might not run a replication just for the video. So here is, and I might not go to 2,000. So here is, let's go to 60 dB. And I'm going in the left ear, and I'm going to press start. So what I want you to watch is I want you to look at the amplitude of the waveforms, and I want you to see that as the intensity decreases, the integrity of the earlier waves will decrease. You'll lose your earlier waves. Those are more cochlear waves. And when I get down to threshold, you're really going to just see wave 5. You're just going to see wave 5 left over. All right, so here we go. Let's start 60. There's a slight little bump in the camera because Maya's breathing deeply. We had to wake her up. She's not going to appreciate me saying that. She is sleeping. All right, so here's the ABR at 60 dB. Let's look at the shape. Let's look at wave 5. Okay. You can see it maturing. You're not seeing the definition of your early waves as you saw before. I'm actually going to move these up. So I can grab this yellow box and move these up. Let me superimpose those a little bit more, just like that. And these actually print out really nicely too. All right, I'm going to stop that. And then I'm going to go down to 40 dB. So actually, this is where wave 5 is here. So let me just mark that. Wave 5 is right there. So you can see that the intense, if you look at these grids, hopefully you can see them. You can see wave 5 is in front of the grid at 90 dB. It's on the grid mark at 60 dB. Now let's look at 40 dB. You can see now that even more of the definition of your early waves is gone, and that wave 5 is what remains. So we're doing a threshold search using a click. And in the clinical sense, when you're testing and estimating thresholds in a baby, you probably wouldn't do a click unless you were looking for ASD, but you would use 500 hertz tone burst, 1,000, 2,000, and 4,000, or you could use chirps. But you would not get the latency intensity increase if you were using chirps. All right, so you can see the definition of the wave is not as great. When you're getting down the threshold, you definitely want to make sure you repeat to make sure that that's not noise. And I could definitely repeat. Let's just repeat it just to show you what repeatability might look like at this level. So I'm just repeating a 40 dB ABR, because someone could argue that that's noise and that's not really the response. And you want to demonstrate, no, that's the brainstem responding to the sound. And look at that lovely wave 5. We only have 600 stimuli right here. So there are lots of people who would stop probably pretty close to 1,000. If you're rushing and you don't have time and you're sure you know that you're going to go lower, that might be fine. But look how pointy and nice that is right there. Isn't that fun? So we're going to stop that there, and I'm going to go down to 20 dB. We typically don't go lower than 20 in a clinical setting because we know that the threshold is probably within normal limits if it's at 20 dB NHL. So this is what a 20 dB looks like. At 20 dB, you're probably just going to have wave 5 left over. So you'll notice a latency intensity function. Wave 5 is earlier. It gets later. As I lower the intensity from 90, 60, 40, 20, you can see that wave 5 has pretty much gone out almost to 8 milliseconds. There's a paper that shows that in a normal hearing adult at threshold, wave 5 is about 8 milliseconds. I believe that's one of them is a Gorga paper in '89. And here you have it. And that's wave 5 there. But I'm going to let that run out to 2,000 hertz because near threshold, you want to make sure you have enough stimuli. And then we're going to do a repeat of that so that I can describe what an ABR might look like closer to threshold. It's really hard to tell right there, it just doesn't look as great. So you want to make sure you have enough stimuli. The amplitude also decreases. So we're going to go do 20, we're going to do 2,000 clicks. Latency increases, amplitude decreases, you get a loss of early waves. So you really have to have a trained eye, and it can be sort of subjective, which is why current research is looking at more and more ways to objectify the evaluation and interpretation of an auditory brainstem response. Which is why we don't show waveforms to patients. I mean, everyone understands a flat line, but you typically don't show waveforms to patients because it can be very subjective. But if a parent is sitting here and the baby doesn't have hearing, there's no explanation needed for a flat line. And so you have to have discussions about whether the parents are in the room or out of the room or whether they can see the screen as you are testing the child. So now you can see, why is the second one always so nice and pointy? That's nice. So there you go. There. On some systems, you can add the waves together to enhance that. So one thing we know, and one thing I say is there a response to sound or is there not a response to sound? And I can say here that there's clearly a response to sound. That's not a nothing. I'm going to show you what a nothing is, a flat line. So I would say that wave 5 is, whoops. is right there. So let's stop that and let's go to 0. And I'm going to show you what a no response is. That's important to note also. So here we have 90, 60, 20, and here's 0. And we're going to watch that mature. And you can see it looks very much like a 20 dB. And after look at the 20, you can see that after the wave 5, you've got that dip, that SN10, that also helps you identify where wave 5 is. But look, that looks similar. Could be that our threshold is lower than 0 also. This is why you have to replicate, so that you can be sure that this is not just noise and that it's a response. If you're unsure, some people say run a third wave. You often don't have enough time in a clinical setting to run a third wave. Oh, look at that. She has the nerve to have what looks like it could be a wave 5 right here, but you can see there's a latency intensity shift as I go down. It could be right there. Look at that. And how would I verify that? I would have to run it again. If not, someone definitely could say that that's noise. Here's my wave 5. I can see that I have a little dip there. It would be amazing if it were to replicate. And it looks, sometimes these early ones can show that to you. You've got a slider on this side too, so you can bring these up. So I'm going to just let it replicate out to 2,000 just for demonstration purposes. Looks like her threshold is below 0 dB NHL. She's got fabulous hearing. And we can have discussions about how to estimate thresholds in class. That's a separate video, a separate discussion. Oh, look at that. It replicates. So there you go. All right, I'm going to stop that. I just want to show you that this is what you do. This is for clicks. We can do this for a 4,000 hertz tone. Let's, in the right ear, let me just do let me do a demo in the right ear since we're here. And I'm going to look at, let's do 4,000 hertz at 80 dB. So here, let me get rid of this here. Okay. Let's do 4,000 hertz at 37.7 dB, and let's do 37.7 clicks per second, tones per second, and I'm going to do 90 dB so you can compare it with the clicks. All right, so this top one, these are clicks, and then I'm going to do a 4,000 hertz tone burst so you can see how they might look different. A 4,000 hertz tone burst looks a lot like a click. There may be a difference in amplitude. There may be a little bit longer latency, but pretty much I expect to see wave 5 in the latency range of the click. So you can see this is wave 5 for the click, and this is wave 5. Let me mark it so you can see it. This is wave 5 for the 4,000 hertz tone burst. I'm just going to stop it there, and I'm going to go down to 40. Let me do 60 so I can replicate what I did on the other side. So so now we're doing 60 dB for a 4,000 hertz tone burst. Here's wave 5 at 90 dB. Here's wave 5 for a click. And what you can do when you're doing your report is where you think threshold is, you can actually put a threshold mark right here so that when someone else is looking at these waveforms, they know what you have chosen to be the threshold. So in this case, I would circle and put a 0 right here. So we would know that 0 dB is the threshold. So you can see here's wave 5 at 40 dB. So let me mark that so it's easier for you to see. Right there. And then let's go down to 40 dB. So you can see the latency, again, you're getting a latency intensity function. As I decrease the intensity, the latency is increasing, the amplitude is decreasing, I'm losing the definition of my earlier waves. And I can see my wave 5 here at 40 dB. It's a little harder for students to see, but I've got an old eye and I can see it. And remember that in the clinical setting, you're going to replicate this. You're not going to just eyeball this, especially if you're going to call that threshold. So I'm going to go ahead and call this wave 5 right there. And I should replicate it if I were going to be using it. You can also see that all right, so there it is right there. And then let's just do 20 so I can show, let me see. Let's do 20 dB. This is a threshold search that I'm doing for a 4,000 hertz tone burst. And after this, the one last thing I'm going to show you is how you can actually use the pencil item to mark your wave. So we're going to try to find wave 5, which, see, I can see wave 5 at 40 dB right here, so I know that there's going to be a shift in latency, a little longer, so I'm going to look in this latency range to find my wave 5 for 20 dB. It's very easy because Maya has normal hearing. When you're dealing with a baby, you don't quite know what the hearing is. All you know is that they've failed the hearing screening, so you can't be as cavalier about it as I am being right now. But I'm going to actually repeat it at 20 dB so that you can see that things do repeat at 20 dB. So that's it. I'm keeping my eye on how many stimuli have been added, but you can see wave 5 popping out right there. I'm going to stop it and repeat that. All right. So I'm always working while I'm doing it. So make sure you're doing something while you're testing. So typically I would be writing what it is. What we do is use the pencil function to put that these are clicks and 4,000 hertz. I'll show you how to do that after that. So I'm thinking that this is wave 5 right here, which means that this is wave 5 right there, and I can verify that by kind of bringing that up like that. If I'm unsure, I'm going to let it go for more than 1,200 stimuli, go out to 2,000. See that I'm going to build that up just like that, just like that. Look at that. See that wave 5 popping up? And look at it nicely aligning with 20 dB before. Look at that. And I can see the SN10, that dip. So this is 40, 60, 90. So if I'm going to mark it, I'm going to go up here to 5. Here's a little cursor over here. You have to click that, click the 5, and it'll mark it just like that. Look at that. All right, I'm going to stop that. Now, because this is different from this, these are clicks, so anybody really could look at this, but the untrained eye wouldn't know how to read this. So let's say I wanted to mark this as 4,000 hertz. I could go up here to the pencil function and come out here, and I could put in 4K. We do this a lot. Hertz. Oops, let me see. Pencil. There we go. 4K hertz. Why isn't it? Erase that part. Okay. Where it says the 4K hertz. Let me. Okay. All right. Let me see why it's not doing. Pencil. Well, I don't know why I wasn't doing it when I wanted it to do it. All right, so I'm going to go back and talk about the label. Okay. All right. Okay, so now I'm going to show you how to label a wave so that there's easy reading, because we have these labels on the side that are easy for us to read because we know the software, but for someone else, the untrained eye for this might not know what that means. So I'm going to click on the I don't know, I call it the Lizzie McGuire icon, but the word icon here, and I'm going to click somewhere on my wave, and I'm going to click the pencil icon, then I'm going to click inside the box, then I'm going to type 4K hertz, and then I know that's what it is, okay? And that's how you would mark it. This will signal the end of this video on threshold searches and retrocochlear diagnostic procedures using the Vivosonic signal averager. Thank you.